Hello? Hello, Fan Williams.
Hello?
Fan Williams, good evening. Can you hear me?
Good evening. Can hear you. Not Sam William, this is Pharmacy Simon.
Oh, Pharmacy Simon. Good evening. How are you?
Good evening, my brother. Fine. Oh.
Well done. Okay. I can hear you very well. Please, did you see the new slide I sent to you?
Yes, but who hosted this meeting? Is the person that hosts the meeting that can share the slides? Yes, the person that created this Zoom is the person that can share. Okay, Fan Williams is
make Ame one of the co-hosts. You can do it. Okay, I can even do it from here.
Okay.
Let me see.
Okay, do it from there.
Let me see if I can do it from here. If I'm enabled, okay.
The slide is already there.
Okay. You can share. Let me bring down my own.
Okay, let me see.
Ahmed, will you want to get it in PDF? I've changed my own to PDF. Okay.
Don't worry.
Yes.
Okay.
Don't worry.
I'll send you the PDF. Send him the PDF.
No, don't worry. I'm setting it as PDF. I want to share now. Don't worry.
Okay.
Yeah.
I will be off in a few minutes because I will be on my way to the house. I will be listening. I will be contributing.
Sorry, I'm trying to do something now. Okay, Fan Williams. Are you there? Are you there?
I am there.
Just meanwhile, send me the PDF version while I'm doing what I'm doing.
Okay.
In case you took it.
Okay.
Yes. Okay. Let me forward that PDF.
Can you send me the PDF?
Let me send
forward
the PDF
to him.
Okay.
Okay. Thank you.
I don't think there's enough work to hire. Why didn't you hire? Since when does she do household chores? Why are you here? Others don't know. Right? You mustn't come. Just get up. You know what? I will tell everyone. We will have the rest to them. If it's when look at them now, when you're now, you won't know me. You'll recognize.
Fan Williams.
I'm with you.
I don't know. I'm not using my system, and I don't know why. I'm not using my system, like my phone is not loading it.
Have you gotten the PDF?
Yes, he has sent it to me.
Okay.
But like my phone is not loading it. I'm trying to share it to the Zoom, but like it's not loading. Oh. From Williams, like my phone is not loading it. Maybe I don't know what's happening. Is it a laptop you are using or a phone?
Yeah, it notifies
My phone is not sending it to this Zoom.
Challenges I'm trying to correct here between now till let me say early February. Along Laura and me. Oh, not to Bobale. I'm on serious heavy loan. He draining me.
Hello?
On a loan can you see? My size loan here, which I miss about 1.4 million every month.
Hello?
Hello, Famame.
Like my phone is not loading it. I'm using a phone. Are you using a system?
Yes. How am I supposed to do it?
The phone will not be able to load it. I mean the card, right? Pharmacist Williams, please, can you just share?
I don't think he's I
Mita,
don't think I do. Yes.
you can share from there.
Okay, how do I do it? I've not done it before.
Okay. Just click on your presentation and the PDF presentation. Click on it.
Okay, from the laptop.
Yes. Once it opens, you click share. Let's see.
Okay. Just hold on. I should open the PDF file.
Yes, open it and then click on share.
Okay. Okay, it's trying to open now.
Okay.
Okay, the PDF is open. So I should
Right.
click on share. I should go to the.
Click on share. When you click on share,
Or
it
the
will show.
Zoom.
Yes, when you click on share to Zoom. Another. Just click on share first, then share to Zoom.
Okay. Where will I see the share?
That sign of share. Are you not seeing any sign of share?
Okay, share screen. Okay,
Yeah.
okay. I should click it. Okay, I've seen it. I should click it.
Yes.
Okay. I've done that. What else?
It's not giving you option. It's not giving you option. WhatsApp, Zoom, or something. It's not giving you any option.
Let me check. Okay. It's not giving me option. No?
When you click on this,
the screen has been shared already, just that it's not in presentation mode yet.
Okay, sorry. Who is talking? Is it Dr. Bello?
Is the presenter.
Pam Stanley.
Okay.
I can see his screen.
Can you see it?
Yeah, yes, I can see your screen, but it's not yet in presentation mode.
Okay. Should I screen share the PDF or the PowerPoint?
Share it as PowerPoint.
Okay, I should remove the PDF.
Yes.
Okay.
Since you have a laptop, it will go as PowerPoint. Then you can be doing something like slideshow there.
Okay. Can you see it? Presenter, are you seeing it?
Yes, sir, I can see it, but you need to put it in presentation mode.
Okay.
Yes, sir. I think the right lower side. Okay.
Is it okay like this?
No, the right lower part of your screen. There are icons there.
Oh, okay. Eta, can you make me the host?
Okay.
Let me share from my end.
From your end. Okay.
Well done. Great attempt. I can see it here. You just to put it on presentation mode, it will just come up.
Okay. It's a
When you
right.
say-
Look at slideshow there or something.
Yes, that one.
Click on slideshow.
Is it okay like this?
Click on slideshow.
Slideshow.
Eta, please, can you make me the host?
Okay.
Co-host.
Okay.
No. Who is moderating? Eta, are you the one moderating?
Yes. So. Can't see.
Meanwhile, while you are waiting for the presenter, have you done opening prayer? Let's do other things, acknowledge people here, and then
Okay.
You are the moderator, Eta, so just start with opening prayer and other things, acknowledging people here while the presenter gets ready.
Okay, Fan Williams.
Fan Williams is here. Can you see the slides?
He said I should make you co-host.
Yes,
Please,
make me co-host.
Please help us share the slides, please.
Okay.
Okay. It's when I become the co-host that I can share.
Okay.
Yes.
Where do I do it?
Just click on my system.
Okay.
Once you click on my own, from that participant, click, you will see different options.
Okay.
Ahmed, do you know how to make one a co-host?
All right, let me click on participants and do that now. Let me see.
When you see participants, you get on my name, Williams Ikemjika. Click on it, my name. It will bring out those things.
What name I okay?
Ikemjika Williams.
The options I'm seeing here is have to start video chat, rename, put in waiting room, remove.
Did you see make a co-host?
I did not see you. I did not see the option.
So who made me a co-host? Who made me a co-host?
I was the one that made you a co-host because I was the co-host.
Okay.
It's just to click on my name. It will bring out some things.
And I'm bringing it up for what is bringing out chat, rename, put in waiting room, remove, mute.
That's the only thing.
Ask to start video.
Are you using your mobile phone?
No, I'm using the laptop.
Okay.
That's
Stanley, are you there?
Fam Stanley. Hello, Fam Stanley.
Yes, sir. I'm very much here, sir.
You are the host. Can you make Fam Williams co-host?
Okay. Let me try that, sir.
Okay.
Okay, while we are doing that, you can start with opening prayer.
Okay.
Let us start. Okay, I'm now the co-host now.
Okay. Good evening, everybody.
Good evening.
Good evening, everybody.
Good evening.
Is pharmacist Ojo Olape around? He was supposed to give us opening prayer. Hello?
Any other person can give the opening prayer if she's not disposed.
Pharmacist Fatima, please, can you give us opening prayer in place of pharmacist Mariam?
Good evening, everybody.
Good evening.
Good evening.
Good evening. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. Incidentally, I'm in the same state with Pharmacist Ojo Olape. She shared the Zoom discussions with us. We thank Almighty Allah for giving us this opportunity to be together tonight. We pray that whatever we are able to learn, we'll be able to use it for the benefit of humanity. May this not be the end of our opportunities. May we have a very pleasant and well-assimilated discussion. To Almighty Allah, we give all the praises. Al-Fatiha. Bismillahir Rahmanir Rahim. Alhamdulillahi Rabbil Alameen. Ar-Rahmanir Rahim. Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina siratal mustaqim. Siratal ladzina an'amta alayhim. غير المغضوب عليهم ولا الضالين. Amen. Thank you.
Thank you so much, Pharmacist Fatima. We really appreciate you for that wonderful prayer. And we say thank you, even though we just took you unawares. But thank you for filling that gap for us. We want to especially thank everyone who was able to make it this evening. Our speaker, Pharmacist Stanley, we are very happy to have you in our midst. Our desk officer, Pharmacist Williams, you've been solidly behind us. We've been working behind the scene and in front of the scene tirelessly since last week for this presentation to take place. We appreciate you. Our chairman, technical advisor, Pharmacist Ahmed, you are welcome. Thank you so much for setting this program up for us this evening. We want to especially thank all members of Urology Pharmacy Group who were able to make it this evening, and other clinical pharmacists from other groups who are here present. We warmly welcome all of us to this wonderful presentation. The title is Kidney and Bladder Stones, Hello, please. Am I being heard?
Yes, you are.
Okay.
Yes, you are.
Kidney and bladder stones, causes, symptoms, and treatment. This topic, we've been waiting for this topic, and we thank God today, finally, the time has come for us to pay our rapt attention to pharmacist Stanley Bassi. Pharmacist Stanley Bassi is a member of the UPON Education Committee, and he has been working tirelessly behind the scene too to make sure this specialty group moves forward. In fact, he is the secretary of that committee, and we want to expressively thank him for all what he has done for the group to be moving. Please, we want to beg your indulgence. Let us all turn our attention to Pharmacist Stanley as he presents on this theme, kidney and bladder stones. Pharmacist Stanley, please, you have our attention.
Christianity. What
Okay.
words do you say?
Thank you very much, sir. Good evening, my seniors. So
Jesus Christ.
just like Ita has rightly said, my name is Pharmacist Makbe Stanley Bassi. I am a YPG, and I'm very happy to be part of the UPON Education Committee group. So
Jesus Christ met great teachers of
my being heard. Hello, can anybody hear me?
We can hear you very well.
Yes, go ahead.
We can hear you. Go ahead. We can hear you.
Okay. So I don't really know all about this topic, but I'll try my best. And I hope that all of us will put hands together and educate ourselves today. So I'll be taking us on kidney and bladder stones, the causes, symptoms, and treatment, and most importantly, our role as pharmacists in the management of this condition. So on the next slide is a picture of please, can we move to the next slide? Okay, so this is a picture of the kidney showing the stones. Actually, Euro sorry, might be here. My network seems to be a little bit fluctuating.
Yes, we can hear you. Please go ahead.
Okay.
Go ahead.
So,
go ahead, fam.
Okay. So as you can see from this diagram, it's just a pictorial representation of a kidney and how the stones actually present inside the kidney. As we move forward, we'll see more. Please, next slide. Okay. The next slide, please. Okay, so in introduction, urolithiasis is defined as the formation or occurrence of stones at any level of the urinary tract, either in the kidney, the urethra, the bladder, or the urethra. It is the third most common you have zoomed it. Can hardly see clearly.
Presenter, but you have a copy on your laptop too, right?
Yes, my laptop is acting up. Actually, that's why I couldn't present with it, sir.
Okay, you can go ahead. Is it okay now?
Yes, at least it's okay now. So it's the third most common pathology affecting the urinary tract. It has been described since antiquity. In fact, this is one of the reasons why we are here, because this in the urology clinic, stones are third most common reasons why patients visit the hospital. Now, the incidence and prevalence of urinary stone vary with geographical location. In the world, for now, we have plenty of these cases being recorded in southern parts of America, especially among the Caucasian race. Then age, it is noted that from fourth decade of our age, this condition present mostly. Then occupation, people that don't take plenty of water, that their work make them to sweat too much, will definitely be at higher risk of coming down with these stones. And also sex. From research, it is found that men suffer mostly from a kidney stone than female, and the reasons is not far-fetched. Men indulge in more of strenuous activities that make them to lose fluid than female, and also part of the lifestyle that men live. Men tend to consume more of alcohol than female. So sex also, in this condition, we see plenty of these cases in the male compared to the female. Now, worldwide, the prevalence is estimated to be 1 to 5% and higher in developed nations. And the reason is not far-fetched. In developed nations, the kind of diet they eat predispose them to this condition than in developing nations like we in Nigeria. But even if this is more prevalent in countries located in the Afro-Asian stone forming belt, it is on the rising trend in tropical and sub-Saharan African countries, like in Nigeria. And the reason is due to global climate change. We're experiencing more hotness and we tend to sweat a lot. And then growing social economic status as manifested by westernized diet and lifestyle. So we tend to now consume more diet that predisposes us to this condition than before. And this also has shifted the site of stone formation from the lower tract to the upper tract. And this, once limited to men, is increasingly gender blind. So more female too. Like then we have the ratio of 10:1. The ratio of male to female is usually 10:1. But now that ratio is actually changing. Okay, so please, the next slide. Okay, so these are types of kidney and bladder stones that are common. Under them, we'll see risk factors that predisposes us to clients to coming down with these stones. So calcium stones contribute 80% of the incidences of kidney and bladder stones that we see in the hospital. And the risk factors for coming down with calcium stones include calcium or vitamin D, dietary supplement, then foods that are very rich in oxalate, including, and these foods that are rich in oxalate, although we'll see more of the examples as we move on, but let me just give you. We have avocado pears, we have dates, we have grapefruit, we have kiwi, oranges, raspberries, Spanish tomato sauce. So this also will form part of our discussion as pharmacists. By the time we are counseling clients that come down with this kidney and bladder stone from time to time, we know that diet is also one of the causative factors that increases the risk of coming down with this. Then the second type of stone that we see commonly that contributes 10% is the struvite stone. This struvite stone is mainly composed of magnesium, ammonium, and phosphate. And the risk factors for coming down with this kind of stone are urinary tract infections, which means male and female that come down with recurrent urinary tract infection are at higher risk of developing this struvite stone. They also have the Proteus mirabilis and other types of gram-negative bacteria, as we can see them. Then the third stone is the uric acid stone. So this one contributes 9% of the incidences of kidney stones seen in the hospital. And the major risk factors here include diarrhea and gout. Then the last one is cystine stones, and that one contributes just 1%. And the risk factors here is a rare disorder called cystinuria. Okay, we'll move to the next slide. The risk factors here explain, apart from those ones I've mentioned earlier on. So some of these risk factors here, we see that the lifetime risk of kidney stone is about 90% in men and 9% in women. Then family or personal history of kidney stones is another risk factor. So which means if we have a family member who have suffered from kidney stone before, or the patient himself or herself had once suffered from kidney stone, there's that high possibility that the patient might suffer from it again in the future. Then another one is dehydration. Excessive sweating or not drinking enough water can increase your risk for kidney stone. And one will then ask, what's the minimum quantity of water one should consume in a day? Then you start thinking of persons that, especially minors, and those persons that don't have source of good drinking water. So dehydration is a very important risk factor when we're considering stones formation in the liver. Then diets high in protein, salt, or sugar. This one also increases the risk of coming down with kidney stone. We cannot overemphasize the importance of minimizing intake of salt, sugar, and the protein. Then obesity too has been linked to an increased risk of developing kidney stones. Then digestive diseases or surgeries. Catheter used for surgical procedures too, and even sutures used for procedures around the kidney can also predispose one to coming down with kidney stones. Somebody who has never had history of kidney stone in the family, but after some surgical procedures, those catheter or the will also contribute. Then other medications will definitely get to medications that can cause kidney stones. Okay, so what are the symptoms of kidney stones? So the client comes down with fever. That one is very short because there will be inflammatory responses. Then stomach pain, vomiting, dizziness, blood in the urine, and backache. Yes, it's very common to have blood in the urine. The reason is that as the stones move down, let's assume it's moving down from the kidney, it's originating from the kidney, as it moves down the ureter to the bladder. If the stone is very large enough, it can erode the walls of the ureter, thereby leading to bleeding. And once bleeding starts, then we'll be looking at infection, fever, and the dizziness that can be caused by anemia also might set in. So we'll move to the next slide, please. No, this is not the next slide. Okay. Okay, so other symptoms include pain while passing urine, going to the bathroom more frequently, pain that comes and goes in waves, urine that appears cloudy, pink, red, or brown, or smells bad. The reason for declaration is the blood, and the smelling bad could be pus formation. Then severe pain around the groin, side, back, or below the ribs, high temperature, fever and chills, nausea, and vomiting. Okay. So common locations of the pains, even in the community practice, when our client comes down with some kinds of pain around the groin or lower abdomen. So this is one disease we should have in mind to actually rule out. So as you can see from this picture, these are the areas when our client come, we can actually ask them to point exactly where the pain is radiating from. So we can move to the next slide. Okay, so what are the examinations and investigations that can be done for clients that come down with such complaint? So one is that we should ask the client history of prior pelvic surgery, just like I mentioned some synthetic materials, including people that are on catheter and those that on were stitched. Those stitching material like Vicryl and others can actually not dissolve completely and will form an area for stones to actually form. Then other physical examination includes suprapubic tenderness, fullness, occasionally a palpable distended bladder if the patient is in acute urinary retention. Then we can also do microscopy of hematuria. Then pyuria is also a very important indicator we should be looking out for, because most times other conditions too that comes with pyuria, that's a pus in the urine, like gonorrhea has that also, and also kidney stone can also present in that form. The bacterial urea, this one is very, very common, especially if there's blood formation or if this kidney stone has been formed by bacteria. Then crystalluria, just like we saw in the second slide, where we saw all the different kinds of stones, the 4 types of stones that make up the kidney stone. So there will be crystals of these stones found in the urine of such client. Then urine culture also for urea splitting organisms. We actually mentioned for especially the struvate kind of stones that gram-negative organisms are actually implicated in the formation of those kind of stones. So we should also do culture test for our client culture and sensitivity for such client. Then other examination we can actually carry out radiographic examinations. So we'll move to the next slide, please. Okay, so urinalysis. Now, the essence of urinalysis cannot be overemphasized, because with urinalysis, we can actually dictate the pH, then we do red blood count, and the leukocytes, full blood count, and all those stuff that we pinpoint to inflammatory responses. Then just like I mentioned earlier on, urine culture and sensitivity test is very, very important, because most times there is implication of a gram-negative bacteria. Then a comprehensive metabolic panel is ordered. This is very important because the creatinine level might be elevated in outlet obstruction. Then other findings may give a clue to an underlying condition. For example, if we do a complete metabolic panel, we might identify if the stone is of the urea acid origin or of the cysteine origin too. So it's very important that we order, if the clinicians don't order for it and the folders come to our desk for us to dispense medication, we should look out for this one, because it will help us. The drugs of choice also vary with the kind of stone that is being presented. So we'll move to the next slide, please. So what are the differentials for this condition? So we have clots, we have fungal ball, we have a papillary urothelial carcinoma on a stalk, and the other differential diagnosis. I think the clinical guys will be in better position to make better use of this tool. So we'll move to the next slide, please. So now let's look at medications that can promote kidney stone formation. Now, this is one of the slides that actually is of much interest to me, because most of these drugs here are commonly used by clients, our clients that come to our pharmacy, that come to the hospital for us to dispense medication to. Now, there are some drugs that ordinarily can promote kidney stone formation. Now, from the first part of that slide, you see increased drug concentration in urine. All these drugs that are listed there, they increase their concentration in urine is increased, and they actually encourage stone formation. And they are very commonly used drugs. For example, we have the acyclovir we used in the treatment of herpes, the allopurinol for treatment of gout, the aminopenicillins, amoxicillin and ampicillin, then ceftriaxone, ciprofloxacin. Now, ciprofloxacin at the pH, cipro can be used if the pH is less than 7. We can safely use cipro. Although from research among the family of ciprofloxacin, I'm trying to remember the
quinolones.
The
Fluoroquinolones.
thank you, sir. The fluoroquinolones. The safest among them is ofloxacin. Cipro is, in terms of the drug that can cause most of this stone, cipro is number 1, followed by levofloxacin. The safest there is ofloxacin. So in case we have a sensitivity test and the client has come down with a gram-negative organism and the cipro, levo, and the ofloxacin are all sensitive, the choice of drug we should go for is ofloxacin. But if we don't have ofloxacin, if the pH of that client is above 7, then we can safely use a ciprofloxacin. They will have ephedrine, magnesium trisilicate, methotrexate, primidone, the protease inhibitors, like most persons that are in the HIV program, the protease inhibitors. So for clients that are predisposed to formation of kidney stones, then this medication we should look for alternative to give to them. Then the sulfonamide, septrin, forms plenty of stone. So we should be careful the way we administer this medication. Then on the lower side, we have altered pH or composition. These drugs also will promote kidney stone formation. Vitamin C, like most times, most clinicians may want to prescribe supplement that contains vitamin C because the client already is passing through a lot of stress due to pain and also due to infection. We want the client to heal faster. They might prescribe medication that contains vitamin C. So let us look at what vitamin C does. So vitamin C will promote calcium oxalate stone.
Alpha, well done.
Okay, so and other drugs too include calcium. Calcium also will promote the formation of these stones. Then the loop diuretics, magnesium containing drugs. So we'll move to the next slide. So now in the management of kidney stones, there's always an accompanying. So the kind of pain that comes is the pain that we refer to as severe pain. So the pain is not just an ordinary pain. It's not a mild pain. The pain is always severe because when the stones, especially when the stones move down the tubes, either the ureter or the urethra, the pain is always very, very severe. So these are some of the medications that are recommended to manage pains that come with this. So when we have the paracetamol, either PO or IV, the maximum daily dose, just like we already know, should not exceed 4 grams. Then celecoxib is also a drug of choice, diclofenac, ibuprofen. So I will just go to the drugs that the opioids. Now we see in the opioids here, butorphanol is not a drug of choice, and so it's contraindicated in the management of this kind of pain. And also meperidine is also contraindicated. Then nalbuphine is also contraindicated in the management of pains that comes with a renal stone. So we'll move to the next slide. Now, there are some medication that can be used for medical explosive therapy. What are those medications that we can use for medical explosive therapy? Medical explosive therapy is the therapy that the client has the stone, so we don't want to use any surgical means to remove the stone, especially for stones that are less than 7 millimeters. Those stones can actually move down our urinary tract. But for stones that from 7 millimeters and above, those ones can really move down. So when we want the stone to move down on their own, this is part of the adjunct drugs we actually give to clients. By the time we get to the case study, we'll see the different drugs. Like now we are mentioning that we'll see how they are being used. You can see that we also use alpha blockers in the management of this kind of pain. We also use calcium channel blockers. So one might ask, what has alpha blockers and calcium channel blockers has to do with the management of pain or the management of stones? So the mechanism of action of the alpha blockers, we all know that the alpha blockers on the smooth muscle will lead to relaxation. Alpha blockers alongside calcium channel blockers on the smooth muscles of the urinary system. Both of them have this synergistic property to cause relaxation of the smooth muscles. So thereby it will reduce the spasm that those vessels actually undergo when the stone is passing through. So by the time we are able to reduce spasm, then the colic will reduce. So as you're using this MET, as the stone is passing down gradually, the client will not feel much pain. So that is how these two classes of drugs come handy here in the management of stones. So both of them, they relax the smooth muscles, thereby reducing spasm, thereby reducing pain. And so the clients, the stone can pass gradually out from the urine outside. Just like I mentioned, stones that are greater than 7 millimeters will require surgical procedures to actually remove. So move to the next slide. So look at treatment modalities. Look at treatment modalities for calcium stones. Now, just like we saw in our previous slide, calcium stones contribute to 80% of the stones we see in clinical settings. So most of the cases we see will look like this. Now, let us look at the etiology, look at intervention, then the dosage and recommendation. So for idiopathic hypercalciuria, remember that we have too much of the calcium in the urine. Which intervention should we use for our clients? I'm looking at the thiazide like diuretics with potassium supplementation. So how does the thiazide diuretic come handy in this condition? Now remember that one of the ways thiazide diuretics act, they act by reducing calcium loss. So there will not be too much calcium secreted into the bladder or the kidney that will lead to super saturation. Because when the calcium becomes too much in the urine, they will precipitate and form stone. So thiazide diuretic come in handy because they will prevent the kidney from excreting too much calcium into the loop. And the dosage is there. We have a hydrochlorothiazide 50 milligram daily or 25 milligram BD. We have a clothalidone, idapamide, then with potassium citrate. The doses are actually them. Or can actually use the potassium sparing diuretics at once. The reason why we are putting in for thiazide diuretic because we're definitely going to lose potassium. So in place of the thiazide diuretics, you can use potassium sparing diuretics. Then resorptive hypercalciuria. So when the osteoclast acts on our tissues and it makes the tissues to lose blood, to lose calcium into the blood, then from the blood into the urine. Most times what is implicated in This condition is the parathyroid abnormally. So we see this one mainly in hyperthyroidism, and the intervention is surgery. We look at the hyperoxaluria. So oxalate is very rich. We have a oxalate concentration in so many fruits and food that in this our area. So in one of the slides, we're going to see some of those food that are very rich in oxalate, so that we can counsel our clients appropriately. So one of the intervention is to restrict dietary oxalate intake. So we advise clients to limit spinach, nuts, wheat bran. Then we have to increase calcium intake. So from studies have shown that for people that are already predisposed to any kind of stone, it's better that they get their calcium from the diet other than giving them as supplement. The supplement plus the one they get from the diet, most times we make we lead to a hypercalcemia, which will definitely lead to hypercalciuria too. So we have those medication there for those people that have too much oxalate in their system. Then another one is when we have hypocitraturia. So citrates actually helps to break down calcium stones. So for people that normally have, this is why when we look at that investigation, we said the metabolic panel of this client must be known. Because if we don't have this information, we don't really know what kind of stone we are dealing with and the drug of choice to actually come. So in cases where it is not specifically stated and the client is before us, if these metabolic panels that measures the amount of ions and other electrolytes in the body are not present, please, we should notify the clinician as part of the intervention we provide to our clients. Just like we can see here, if a client has low oxalate in the blood, calcium stones will definitely form. Then another one is a when we have too much uric acid, actually. So for clients that have too much uric acid in the urine, the reason we can provide for them is we restrict dietary protein intake. Then we give xanthase oxidase inhibitors. Then we can also give urate oxidase enzymes. So these are some of the interventions we can provide. These interventions are very, very essential. I pray by the end of this slide that the presentation, especially this particular area, can be shared so that we all have the information handy. So we'll move to the next slide. So how do we treat other stones? How do we treat other stones? So for uric, it's for stones that are caused by uric acid. So the intervention is to provide alkali citrate preparations. For example, we have potassium citrate to be given 40 to 60 milli equivalent of citrate in 24 hours in divided doses. Then we also give sodium-based preparation. I give sodium bicarbonate 1.3 gram twice daily. Then for stones that are formed by struvate, the struvate kind of stones, what intervention? Remember we mentioned earlier on that the struvate kind of stones are normally formed by the gram-negative bacteria. Once you see a struvate stone, know that there's an underlying infection, bacterial infection that has actually happened. So if test is not or that there's no culture and sensitivity test, then we should provide that intervention. So like we mentioned, we use the urease inhibitors. Now, the urease inhibitor we have here, the acetohydrozamic acid, AHA. So this one should only be used if surgical operations did not resolve the problem. So this particular drug is reserved if surgery has not resolved the problem for people that have recurrent stones. Then antibiotics, we can give short duration, just like I mentioned. For pH greater than 7, don't give ciprofloxacin. Floxacin is the safest aminoglycoside that we actually need for this kind of condition. Then we have the urine acidifiers, including, just like we mentioned, if we see here the etiology, urine pH is always greater than 7. So which means the urine of clients that come down with this truvate is always in the alkaline region. And these gram-negative organisms actually thrive very well. In short, they're the main factor why the urine becomes alkaline. So they thrive very well in alkaline environment. So for such condition, we have to give urine acidifier, something that will reduce the pH of the urine. And most of the medication there is ammonium chloride, 1 gram BD or TID as a case, maybe methionine, betaine, and cranberry juice. Then we'll move down to the last one, the cysteine. Now, for cysteine, the etiology is normally genetic autosomal implication. So what intervention should we provide to such persons? We have to restrict dietary intake of sulfur. So we have to limit intake of meat and dietary products. Now, one can ask, how does cysteine come in place so that how does limiting intake of proteinous food improve the quality of life of people that come down with cysteine? We already know that proteinous food during metabolism, they are metabolized to purine, and purine is a precursor of cysteine. So the more they take food that are rich in protein, then the more they will produce cysteine and the more the condition will worsen. So for clients that come down with this kind of stones, we have to restrict their intake of dietary food, especially food that are rich in protein. For the intervention we should provide as pharmacists, the non-pharmacological approach. Then we have the alkali citrate preparations. Then we have the sodium-based preparation also. Then we have the thiol binders. So we'll move to the next slide. Now, pharmacist counseling on diets. From this slide, we can see food that are very rich in oxalates. Remember, we mentioned that calcium phosphate, and calcium oxalate contribute 80% of the cases we actually see. So which food actually rich in oxalate that we should advise our clients who are having these stones to actually avoid? We have potatoes and yam. So at the end of this slide, you ask yourself, so which food, like for a normal Nigerian? Because potatoes and yam is one of the stable food we have here. We have legumes and beans. So they should avoid this one. We have seed and nuts, wheat bran, soy. We have raspberry, spinach. We have chocolate and cocoa. We have processed meat, pumpkin, eggplant, and grapefruit juice. These fruits will contribute to making the condition worse. But food that we should encourage our clients that come to a condition to actually eat. We have coffee, we have low-fat dairy, like skimmed milk will be recommended for such class of people. We have banana, we have pawpaw, we have water with lemon to alkalinize the urine, we have broccoli, we have iceberg lettuce, we have pepper. So these are some of the food we should encourage our clients that have come down with this condition to eat as part of counseling we actually provide. So having gone through the etiology, signs and symptoms, then the drugs of choice and how we come in as pharmacists, and also counseling on diets, let us look at a case study. Please, the next slide. So look at a case study. So a 52-year-old male presented to emergency department with severe right flank pain, radiating to the right lower quadrant. His blood pressure was 154/96. Pulse rate was 79 beats per minute. Respiratory rate was 25 breaths per minute, and temperature was 38.7 degrees centigrade. The pain was insidious in onset and had an intensity of 10/10 on verbal analog scale, which decreased to 8/10 after administration of IV ketorolac and morphine medications provided in the emergency department. The pain was constant, lasting 3 hours in duration, and he had 2 episodes of emesis since its onset. He did not report experiencing any chest pain, dyspnea, bowel, or bladder dysfunction. His medical history included a similar pain in the left flank 2 years earlier, which was diagnosed as kidney stones. His heart rate and respiration were within normal limits. He did not display any sign of edema, abdominal discomfort, or indigestion. His abdomen was soft with diffuse tenderness, which increased over the right lower quadrant. The analysis revealed a moderate increase in specific gravity, 1.03, significant hematuria, +3, pyuria, pH of 7.4, and a trace of protein. So a right ureteric calculus was apparent on a conventional abdominal radiograph. He was discharged from the emergency department with the hope that he would then pass the stone naturally. Unfortunately, the following day, the patient returned reporting that the medications did not significantly affect the pain. And his referral to the urology department was expedited. A CT scan was subsequently obtained, which revealed a 7mm calcified density in the right proximal ureter with associated moderate hydronephrosis and perinephric stranding. Multiple 1 to 2mm non-obstructing calculi were additionally noted in the left renal parenchyma. The patient was diagnosed with the right ureteric calculus and was further managed for the pain and was booked for surgery. Then, as you can see on the next slide, that is the radiography showing us the calculus as found in the kidney and the bladder. You can see them in point A and point B. The dots might not be, okay, point B dot is somehow visible from this picture. So the treatment plan for the patient, this is what the clinician prescribed. Tab cocodamol 2BD times 1/12, tab VC 1 gram OD for 1/12, tab ciprofloxacin 500 mg BD times 1/52. Client was booked for surgery in 1 more time as he did not have the money as at this time. So as pharmacist in the dispensary, this folder has been brought to us and the client is there for us to attend to. So from the little presentation, from the little stuff we have learned, so what intervention can we provide for these clients? What is it that has not been done properly well for this client? From my own side, which I may not be 100% correct, which I may not exhaust all the points. Now, one, there's a drug therapy problem. We know that one of the major causes of kidney stone, as we saw in the earlier slide, is loss of fluid through sweating. So drug therapy problems, the client needs additional medication. Now, client needs to be given IVF fluid, at least 1 liter, 5% dextrose plus half liter of normal saline, TDS, till the day of surgery. Now, one of the causes, and the reason for this, one of the causes and promoter of increases in stone formation is dehydration. We should also note that as one of the risk factors, we mentioned earlier on that increased intake of salts, sodium, is also a risk factor for formation of stones. So for clients that need, definitely clients that have kidney stone need rehydration. Now, for these clients, normal saline is not the fluid of choice because sodium is also implicated in formation of these stones. And one can say we mentioned sugar as part of the risk factors. Yes, the contribution of sugar to the formation of stone is lesser compared to sodium. Sodium, in terms of want to compare the both of them, the ratio of formation of stones, sugar to sodium is 1:50. So the clinician needs to prescribe IV fluid for this client because for this client, even though the pain was very severe, surgery should have been done. But since the client is kept till 1 month time, we need to hydrate the client. Then ciprofloxacin should be replaced with ofloxacin, since in the presence of pH greater than 7, as you can see that the client pH was greater than 7, cipro will encourage formation of stone formation. So we meet the prescriber and said, "Sir, please, we need to actually change cipro to ofloxacin." Remember that we also noticed that there was pyuria. I mean, there was pus in that client's urine. Then we move to the next slide. And vitamin C also should not be dispensed because vitamin C will decrease pH and increase the formation of more stones. Then the client also needs additional medication because for this 1 month, giving opioids only, cocodamol and paracetamol only, will take care of the pain, but the spasm that will now allow the stone to move down gradually will be taken care of by our alpha blocker and the calcium channel blocker. So the doctor did not prescribe either of them. So nifedipine will also, remember that this client also has elevated blood pressure. The blood pressure of that client is 154/96. So here now, the nifedipine will serve dual function to also help to reduce the blood pressure of the client. Now, from that client, we also saw that there was blood in his urine, and the doctor did not order for HB or PCV, that we know if the client is anemic, because this is one thing also that comes with stones, especially when the stones are big enough. As they move down those tubes, they can corrode the walls and the blood will be lost. So PCV, so that we can know if the client is eligible for blood transfusion or blood supplement. They should also educate the client on diet and lifestyle modification. And also, this is one area that the doctor failed to mention. You know, there should be a clear history of the lifestyle of this client, especially diet. He did not state that in his clerking. So that is also very, very important. And also the type of stone. Remember, we mentioned earlier on that the type of stone identified will actually guide us the type of treatment we give the client. So for this client, the type of stone that was identified for this client was not even mentioned. So going ahead, although this is just, well, I say, a supportive treatment, but then we should make
Slide 7.
so order for that. So that's the end of my presentation. Thank you for listening.
Thank you so much, Pharmacist Stanley Bassi, for that wonderful presentation. In fact, I will call you the kidney stone man, because I've learned a lot about kidney stone from this presentation. However, am I being heard?
Yes, sir.
Okay. So, as I was saying now, we have learned a lot from this presentation, and from the chat, I would like those of us who have questions or reaction, either post it on the chat or by way of indicating their hand. Let us reach out to them. However, we want to use the opportunity to welcome most of our colleagues that join us shortly when the presenter started. We appreciate all of you for coming. We appreciate you. From the chat box, Pharmacist Fatima have said that we should share the presentation. Yes, we are going to share it. We will share the presentation at the end of this presentation will be shared. Okay. Pharmacist Adetunji's hand is up. We'd like you to unmute yourself and speak.
Okay, thank you very much, moderator. Thank you also to the presenter. It's very, very explicit presentation. Thank you so much. As someone who has been a direct patient of kidney stones and required surgery, I find a lot of these things very familiar. I just want to pray that, like you said, those of us who may not belong to the platform will get this like one way or the other. You will leave our email because things I've picked up on this presentation will help me to do post intervention, modifications of lifestyle. Those are the things I'm particular about. I also have one quick question, which I like to think that in this case where the hydronephrosis was indicated, is it really going to be the best way to go by intravenous fluid augmentation for that longer than before surgery? Because I know I was told to drink a lot of water, but it kept causing problems. And so it had to be done with some back and forth. So I don't know. It just feels a bit awkward to say, okay, let's go with IVF, because that one becomes a bit out of the patient's control. We cannot moderate how much water goes into the kidney at the time. So I just like that clarity on this particular area. So like I said, once again, I hope the slides will be available for those of us who did not join from the platform but came from other platforms. If we have to leave our email address. Thank you.
Thank you so much, Pharmacist Adetunji. We appreciate that comment. We would also like you to drop your email in the chat box so that we'll send the slides to you. There is a question. Presenter, can you hear me?
Yes, sir. Please
take down this question. There's a question here from pharmacist Rosaril Agbim. She said, I'm just wondering if the patient is not hypertensive, won't the tamsulosin or CCB lower the BP? Please take that down. Did you get that?
Yes, sir.
Okay. Let me check the other question. Any other question there? Okay. Pharmacist OY ask this question. Say, thanks for your presentation. My questions are those. One, how much emphasis is placed on stone analysis? Is it routinely done in facilities to determine the composition of the stone, since composition guides treatment? Two, please expatiate on the role of urinary pH in the management of urolithiasis. Have you gotten that?
Yes, sir.
Okay. From pharmacist Aisha Abdullahi, we have this question. Please, could you kindly shed more light on patient rehydration? Because the patient cannot be managed for 1 month with rehydration TDS. With rehydration TDS as an outpatient and keeping him as an inpatient for that length of time is not cost effective. So please kindly share light on that point. Okay. Let me search for any other question. Before we take the next question from the chat box, we would like to acknowledge the presence of pharmacist Ismail. He has been raising his hand. We would like him to unmute himself and ask his question or make his speech. Please, pharmacist Ismail. Pharmacist Ismail, can you hear me? Please unmute yourself. Okay. Presenter, are you there?
Yes, sir.
Okay, let me go to the chat box and check other questions. Let me read that other questions. Okay, from pharmacist OY again. So on your case presentation, since the pH was greater than 7, why is the urine acidifier vitamin C a wrong drug? Okay, I think that's all we have for now. Mr. Presenter, please, can you start answering the question for us?
Okay, sir. Okay, so thank you everyone for your contributions and your questions. So I will try my best to answer them to the best of my knowledge. Anywhere I don't get it, I believe I'll get help. So let me start with the last question. Since pH is greater than 7, why is the urinary acidifier vitamin C a wrong drug? Now, vitamin C will decrease the pH. Now, if once it decreases the pH, it will promote more calcium oxalate stone formation for this particular client. So especially for calcium oxalate stones, pH, acidic pH encourages their formation. This pH stuff actually varies according to stones. For example, let me just state instance of what pH can actually do to the different types of stone. Now, pH that is less than 5.5, we promote uric acid stone formation. So as we are acidifying this particular, we are acidifying this client now, we are at risk of forming uric acid stone. Then urine that is greater than 7.0 pH, we promote struvate stone formation. So the pH is not really cast on stone. It all depends on the pH gives us idea of the kind of stone that will be formed. Just like I mentioned, one of the things that the clinician didn't do very well is to help us identify the kind of stone that we are treating. So, but since we know that most of the cases, 80% of them come down with this, it's just an assumption. And we now, we don't want to actually say, okay, let's just follow it blindly. We have to also prevent possible interactions like this. Now, calcium phosphate stone may also form as a result of a urine alkalinization. So any urine that is greater than 6.5 will have more of the calcium stones form. So we now see that different kinds, the 3 stones form at different pH. So that's why we are saying that particular drug, even though we don't know the kind of stone, the clinician didn't tell us, but we are just saying it shouldn't go. Then I say I should shed more light on rehydration, because you cannot manage a patient on IV fluids for 1 month. Yes, that is where we actually come into as a pharmacy, just like we identified, this is a problem that the client will face. So what do? We have to encourage our client now for liberal intake of fluid. Now, let us also remember that most of the fluid, like I spent some of my life in Ogoja, the water in Ogoja is hard, which means it contains plenty of calcium and other hard metals too. So the kind of water we actually ask our clients to take is also important. If the water is rich in some of these minerals like calcium and magnesium, we are actually exposing our clients. So that is why the metabolic panel is very important, because if a client already has, let me say, has reached the maximum level of the quantity of calcium in the body or magnesium in the body, and the client is taking something rich in magnesium, we are worsening the client condition. So in such cases, since it's not very feasible, we have to educate the client on fluid intake. Okay, so the next question, okay, I've actually explained the role of pH in the management of stones. Then how much emphasis is placed on stone analysis? Well, this is one area we as pharmacists needs to come in, because we have seen from this presentation that for a more comprehensive scientific management of stones, we need to know the kind of stones we are dealing with. So by the time the clinician is not ordering for analysis of the stones, we might just be treating blindly. As you can see, depending on the kind of stone, it has its own treatment. So it's one area we should come in the hospital and also in our practice to emphasize the importance of knowing the kind of stone before we actually treat. So another question is, won't tamsulosin lower BP, assuming the client is not hypertensive? Yes, tamsulosin will actually lower the blood pressure. This is one of the reasons why we should encourage the client that even though he has been given 1 month to go home and stay, BP monitoring should be checked. Like we mentioned that the mechanism of action of tamsulosin and nifedipine is by smooth muscle relaxation. So if the BP is very low, we are running a risk of having hypotension. So we may have to stop the tamsulosin and nifedipine, then continue with the NSAID and the opioid to take care of the pain while it moves down. But these 2 drugs actually give additional support to our NSAIDs. So I don't know if there's another question that was asked that I actually missed out.
Okay. Thank you very much. I believe you have answered all the questions. And pharmacist Aisha Abdullahi in the chat box actually sent a contribution I would like to read out. She made a contribution. She said, your intervention as pharmacist should be liberal. Your intervention as pharmacist should be liberal fluid intake, not rehydration with both dextrose water alternating with normal saline. Presenter, did you hear that?
Yes, okay. I heard that. Okay, let me respond to that briefly.
Okay.
Thank you, Isha, for your contribution. Actually, in the management of stones, fluid, we know that one of the reasons why this actually happens is because there's not enough fluid in the system. In short, the pain on its own, by the time the client they are thinking about going to urinate and the pain are going to feel, it makes them not to take much fluid. And that on its own will increase, just like we saw in this client, is the specific gravity of the urine increased due to concentration of some minerals. So this client, definitely, the volume of water in their body is not enough. And for the usage of why the term rehydration was used by the bodies is to actually place much emphasis that rehydration is one of the major ways of tackling this. In short, it's both a preventive measure and also one of the measures that during treatment is actually used. So in either ways, at least for this particular client, since we are dealing with this client, we will say liberal fluid intake. I agree with you completely, but I had to come for other cases too. Unlike this, because this client is actually going home. So I agree with you completely on that.
Thank you so much, Pharmacist Stanley, for that wonderful comment. Before we ask the next question by Dr. Ajay, we just want to appreciate the presence of Dr. Agada Echefu, the chairman of CPAN Cross River State. Even though his schedule is very busy, he was able to make it this evening. We also want to appreciate the presence of Dr. Timmy, and we also want to use the opportunity to tell her that even after all what they have passed through in Bayelsa State, because of the flood, we are still behind them. We are behind all the pharmacists, our CPAN members, we are behind them, and we have them in our prayers. Thank you so much, Dr. Timmy. Even in the midst of the flood, you were able to attend. We also want to thank Dr. Biajuru. She was able to attend this evening, even though she has been very, very busy. We thank everybody who was able to make it. However, before we close, we want to ask this last question from Dr. Ajay. Presenter, are you there?
Yes, sir.
Okay, Dr. Ajay, here is his question. How do we obtain stone sample for analysis? Is there any lab in Nigeria where stone analysis can be done?
Okay, so basically, I may not have this answer very accurately, but as to mention the labs where it's done in Nigeria, but I'll give ways how this can be, how we can go about it. Now, when the kidney stone is actually there's this part of the presentation I didn't bring in about examination. For examination, especially when we use the lights, where's that slide? When we use a CT scan, ultrasonography, some of these stones can emit some can absorb light, while some absorb and reflect, while some absorb and don't reflect light. So if we run an analysis of the stone, we can scrape some. We can run analysis for calcium. There are reagents in the lab that are used to identify calcium. the reagent the lab can use to identify all valid during farm chem experiment those days where we do some analysis. Those ones are routine analysis that can be done in analytic labs. So for people that the scientists that specializes in metabolism and other stuff, I do the chemistry of the body, looking at all, like for example, you can actually get, I want to know the amount of calcium in my blood. You can go to a lab and they'll run that test for you. The same way too, when we get the stone, we can scrape some part of it and run the test. We're looking at calcium, we're looking at oxalate, we're looking at uric acid. These are little tests that can actually be actually done. But as for the specific lab that I know, like here in where I work in hospital, in Holy Family Catholic Hospital, we can actually do those basic cation tests with blood. So the same way too, we can actually identify them in the stone. So yes, it can be done in our respective labs. I don't know if I answered your question, sir. I also need contributions from other team members too.
Thank you so much, Pharmacist Stanley. We really appreciate the way you handle this topic. You know, when it comes to management and labs, some of these things may not be readily available. However, we believe that as the Europharmacy specialty group continue to evolve and move from strength to strength, we will continue to enlighten not just the public, but also our members on even labs that handle issues that have to do with urology and related specialty. Dr. Ajay's hand is up. We want to appreciate your presence, and please can you unmute yourself and ask your question, please.
It's all right. It's just okay. Good evening, colleagues. It's just a comment.
Okay.
To say that this topic is very, very relevant because of the impact on those who suffer from it. Because my wife had kidney stones for quite some time, and I know firsthand the symptoms and all of that. Now, the fact is that the stone is really a stone. By the time it came out, fortunately, before surgery was done, it's just like a rock, very, very strong. And the fact is that stone analysis is to help you prevent reoccurrence. In actual management, if the stones are not excreted, it's nearly impossible for you to begin to analyze it. It's nearly impossible. So, but after maybe surgically, removing the stone, or maybe the person is fortunate, then you can do analysis. That's just what. And in course of trying to get relief, we're told that it's only in South Africa that they could do analysis. So that's what is informing my question. So I think there would be a need to do a second one of this topic with more emphasis on some of these questions that we've asked. So I want to thank the young man. He's done a very good job. Thank you.
Thank you so much, Dr. Ajay, for that real life experience. We are happy to have you, and we really appreciate the real life experience you just related with us. We have a comment in the chat box from Pharmacist Adetunji. So how does one become part of the urology pharmacist group? I would suggest you just drop your number. We'll get back to you after the presentation. Thank you so much. Thank you so much, Dr. Ajay. As at this point, we want to thank everybody for being able to attend. At least we have been able to exhaust all the questions, and we appreciate all those who made comments. We want to thank the presenter, though it was a very short time, but he was able to come up with a very good material. And for future presenters, we want to appeal that you send in your slides to us at least 2 weeks before the presentation date. Ladies and gentlemen, at this junction, we would like to bring the meeting to an end by calling Pharmacist Ogbuosita to close us in prayer.
All right, thank you, the moderator, for today's presentation. Shall we pray? Thank you for being with us from the beginning to this ending. Thank you for what you have planned, what you have helped us to increase our knowledge, our profession, to move forward. What I would say, may you continue to strengthen us, to keep moving higher and deepening our knowledge in the way to help patients and relatives to be in better health. Pray may you contribute to us in the subsequent presentations. At the end of everything, may we all work together for the improvement of patients we take care of, our profession, taking to greater height. All do see as Jesus Christ our Lord. Amen. Thank
Amen.
Thank you so much, Pharmacist Osita. We appreciate you and thank you all, and we wish you a good night's rest. Mr. Presenter, we appreciate you.
Thank you very much, sir, for the opportunity.
You did a good job for us. Thank you so much. Please, Pharmacist Stanley.
Yes, sir.
There are some people that drop their names and number to join the urology group. I don't know. Can you see my system is hanging? I'm trying to in the chat box. Okay. So. Pharmacist Williams.
With you.
Have you got to home?
Yes, sir.
Sorry, I say let me not call you whether you're on the steering wheel.
I understand. Pharmacist Stanley, very well. You did excellently well. I'm so proud of you, sir.
Well done. Well done, sir.
Thank you very much, sir, for
thank you, everybody. Thank you, Pharmacist Sita. Thank you, Pharmacist Stanley. Thank you, Pharmacist Williams.
Thank you, Pharmacist Ahmed.
Let me thank Pharmacist Ahmed very well.
Yes.
He was just coming from a very hot service and he was able to make time. Sir, I salute your courage, your commitment. Thank you very, very much. I'm so happy that you was. Thank you.
Thank you.
Good night. Pharmacist, you were wonderful.
Thank you, sir. We appreciate all of
you. I'm so happy.
Thank you very much.
Okay.
Pharmacist William, please, how do we get these numbers from the chat box?
This number from the chat box?
And the email address? Yes, can you hear me?
Can you write those numbers?
Yes, I'm screenshotting them.
Okay,
So,
beautiful.
please just hang on. Don't take down the slide yet.
No, we will not. Just screenshot them. Mm. Some people send their email as well.
Pharmacist Williams.
I'm with you.
There's a message I just saw now. So that after you may work on it. My name is Oyiye. I represent a company in the process of bringing in products for kidney stone management. Hence, my interest in this. Can you please drop your number or email address so we can speak further on this and future collaborations? Since I can see you guys, you have a bias for kidney stone. I can be reached on this or this. Please,
can you copy her number because I can't see her.
Okay. Okay, I've seen her number. Okay.
We'll reach out to her.
Okay.
Okay, sir. I finished taking the screenshot, sir.
That's beautiful. So I was to see our meeting supposed to be when Thursday. Our meeting is on the 10th.
Yes.
Okay. Another meeting 10th.
Yes.
At least by next week we start and I want to really thank all of you. I want to thank all the education committee members. Excuse me. I want to thank Sadiq. Hawa Sadiq was very fantastic. She was the one sharing almost at any platform you see. She was always there. Hawa, are you with us?
I didn't see her.
No, she's here.
Is she here?
Yeah, she's here. Hawa, good evening. Hawa, can you unmute and speak to us if you are still awake? So I really want to thank each and every one of us, even our DEX officer too, who could not make it because of some reasons. We are just talking when you called. She really wanted to be here, but she couldn't make it. So I want to really thank all of us. We really worked at it like a team. Within a short time, we only had Monday till Wednesday.
Yes.
And I think we did well. Thank you, everybody.
Thank you so much. Please, Pharmacist William, when you get the screenshot, you help us follow up with that rep.
But you copied the rep's number now.
Yes, I've copied the number.
You can send the number to me.
Okay,
I will speak to the rep. Yes.
Okay.
If she's a pharmacist, automatically she's going to be one of us, because I know a lot of people joined that are not pharmacists.
Okay.
So we'll see how it goes.
What about these persons that drop their numbers and are interested? How do we go about it?
We'll reach out to them. Okay. What Pharmacist Stanley will do after the screenshotting, you will now write those numbers, probably send to our education committee group.
Okay.
Or you send it to me so that I can share it with the DEX officer too. We can follow them up.
Okay. That would be good.
Yes, sir. Yes, sir.
Pharmacist Stanley, we appreciate you. Thank you so much. You did well.
You tried.
Thank you, sir.
I bet try and rest well. I know how it could be.
Yes, I'm actually going back home now. I had to stay back so that I can have light. Yes.
Wow.
Okay. Thank you so much, everybody.
Okay, thank you.
Thank you very much.